Hello, everyone. I'm Dr. Crystal Jicha. I am a headache specialist at UCI.
And I'm Dr. Sam Spiegel. I'm one of the neuro-ophthalmologists here at UCI. Dr. Jike and I work together a lot. We're both neurologists, but we're in separate departments here. So I work in the ophthalmology department, seeing our ophthalmology patients. She works with the neurology department and sees headache patients. And hopefully we're going to do a nice talk tonight for everybody on headaches and kind of our approach to management and a couple of specific topics. So to go over our talk today, we're going to start. I'll give a brief overview of just quickly what migraines are, so that we can get a good intro into a couple cases. Then Dr. Jack and I are going to trade off talking about a couple specific topics that we find pretty relevant to headaches, migraines, and then we'll do a quick wrap up at the end, and then go over any questions that we have. So, what is a migraine? That is a great question. It is a disorder that's characterized by episodes of headaches that are specifically have these associated symptoms with it. Generally, you can think of it as episodes of headaches that have associated nausea, light or sound sensitivity, but there are specific criteria that we can look at that will help define headaches more, and we're going to go over a couple of those examples too. So we always think about headaches or migraines specifically as the headache phase, but it is really this an event that happens, and it can be broken down into 4 parts. So it starts with this prodromal phase before a headache, and some people don't even acknowledge that that really is part of their migraine, but it comes with these mood changes, difficulty concentrating. Some people yawn before a headache even. And then it goes into the aura, which is more just before the headache. Not everyone experiences these classic symptoms, but when it does happen, people can get 5 to 60 minutes of symptoms that are either sensory symptoms like vision changes, hearing, tingling, and then followed by more classically the headache, which everyone associates and thinks about when we think about headaches and migraines, that have specific qualities that can help us kind of differentiate different types of headaches. And then it's followed by this postdrome or this phase after the headache as people recover from it. So to get into some of the more nitty-gritty details, this is just the criteria from the internal classification of headache disorders. So when we think about a headache and a migraine, we have these criteria that can help us put patients into the right box so that we can get appropriate treatment in place. So for migraines, we're thinking about headaches that generally are 4 to 72 hours. They're of course, with taking medication, it can shorten that. And then the headache should have a couple of qualities. And that was when I was talking about that kind of syndrome that we call a migraine. So it should have some of these, not always, but it should be unilateral at times, pulsating, moderate or severe pain, and aggravated by activity, things like walking, bending, exercise. And then during the headache, you should have at least one of the following bullet points there. So nausea and or vomiting, and then photophobia and phonophobia, which is sensitivity to light and sound. Some people don't necessarily notice that like the light sensitivity is as prominent, but you know, it's people will put on sunglasses at times, but sometimes just that it's just more bothersome than it otherwise would be.
Photophobia and phonophobia.
So a lot of what we're going to talk about today is migraines, but there's a lot of different types of headaches and a lot of different things that cause headaches. So we also classify them into primary headache disorders, so things that are primary, as in they don't have another cause of something that's another medical condition that's presenting like headaches. So migraine is one of those. The most common one that we think of is tension type headaches, and that's that kind of typical tension headache on both sides of the head that's mild, and a lot of people will, you know, just take Advil and not really think that there's too much wrong and bring them to see a doctor for. And there's a lot of secondary causes of headaches. Things like high blood pressure and sleep apnea can be causes of secondary headaches. So migraines are not only really prevalent and really common, but they've been around for a long time. Uh, Actually, some of the earliest documented migraines were in ancient Egyptian times. They found old Egyptian virus from like 2500 BC. You can see this was actually one of the drawings from then, and it was a crocodile wrapped. There's herbs in the crocodile's mouth, and it is wrapped around the patient's head as they are suffering a headache or migraine attack. Um, at least we can infer a migraine from this photo. A headache, we'll say. And then there was a lot of important people in history. I included a couple that I was looking through when I was putting together this talk. Take what you say about which famous people I chose, but I thought it was really fun to see who was affected by headaches. Everyone from Julius Caesar to Ben Affleck.
So now we're going to go over some specific cases that, can hopefully teach us some things about headache and about migraine and maybe how to deal with them. So our first case is Virginia, who's a 30-year-old female coming into the office for headache. She reports a headache started when she was a teenager. They're severe, robbing, located behind the right eye, and are accompanied by nausea, light, and sound sensitivity. Hopefully, some of this is starting to sound a little familiar after that little intro Dr. Spiegel gave. Virginia's having about one headache day per week and is noticing they tend to occur more around times of stress or nights when she didn't really get a good night's sleep. So we diagnosed her with migraines. Again, that unilateral pulsating severe pain with the associated nausea and light and sound sensitivity is very classic migraine. Now, our patient's interested in discussing what may be triggering her attacks and what options for her headaches that she might be able to kind of initiate on her own. She's also not crazy about the idea of medication, so would prefer to do this without pharmacologic medication. So, what kind of options does she have? What can she do on her own to improve her headache and migraine? Now, kind of our mainstay of headache migraine care is lifestyle advice. There's plenty of things that can be done in day-to-day life that can make headaches not as common to occur, make it less likely to trigger a migraine event. And we're going to talk a little bit about each of these. Sleep. Sleep is so important for life in general, but is a very, very well-known trigger of headache and migraine. That's migraine, that's tension type headache. So some basic sleep practices that can be helpful in day-to-day life, and what I like to counsel my patients on are to set up a routine. Going to bed at the same time every night, waking up at the same time, having a consistent sleep schedule, creating a good environment for sleep. So that means things like not using the bed for your day-to-day activities, really reserving the bed for bed and nighttime activities, so that your brain makes that association with sleep. Reducing electronics before bedtime. We all have phones and those awful blue lights that like to stare at us and stimulate our brain, keep us awake. So putting that away can be really helpful. Reducing large fatty meals right prior to sleep, which can interfere with that process. And then things like stress reduction, exercise can be really beneficial for getting a good night's sleep. And limiting caffeine, which is obvious, maybe restricting it to the morning hours, not ingesting at nighttime or in the afternoon, and really limiting fluids in general. If you're somebody who already gets up in the middle of the night to use the bathroom, you might want to restrict fluids an hour or two before bed so that you're not getting up quite as often. Now, diet. I get this question all of the time from my patients. What kind of diet will help my migraine? Now, many different diets have been studied. There's page after page after page after page of headache and migraine books recommending different types of diets, but at the end of the day, no one diet has kind of come out in the lead when it comes to headache and migraine care. So my general recommendation is to think about a heart healthy diet. Lots of fresh fruits and vegetables, proteins, healthy whole grains, and in the right proportions, using water as your drink of choice as opposed to sodas and fruit juices. This is basic dietary advice that, people get for any number of medical conditions, but can really be beneficial for migraine. So can hydration. Seems very simple, and that's because it is, but lots of people aren't good at staying hydrated. So making sure you're getting an adequate amount of water throughout the day. Dehydration is, again, very well known to be a migraine and headache trigger. Exercise. Any type of exercise that we have studied in migraine has been shown to be beneficial. So this includes aerobic activities, meaning cardio, things that get the heart rate pumping, running, biking, swimming. Weight training and strength resistance has shown benefit in helping with headache and migraine. Even things like yoga and Tai Chi have been shown to improve headache and migraine. So it really doesn't matter what type of activity you choose, just choose something that works for you, and you're likely to see some benefits from that for your headache and migraine, in addition to other aspects of your health and life. Now, another thing that I like to talk with my patients about is posture and really strengthening the neck. This can be very beneficial in headache. You see from this diagram here that every inch of forward head posture can increase the weight of the head on the spine. Putting pressure on the spine can cause degenerative changes to happen. That could put extra pressure on nerves, which can then increase headache pain, increase tension in the neck and the shoulders, all of which can help to create headache. So working on the posture and working on strengthening those muscles that help to support the head can be really beneficial for kind of taking some of this extra weight and pressure off that could be contributing to headaches. And then stress reduction. This is the one that always gets an eye roll when I tell people to work on reducing their stress. But there are ways that this can be done, and this is very beneficial. I'm sure if any of you have had a headache before, you've recognized times then increased stress has maybe led to that headache event. And again, this can be very simple things you incorporate into your routine, or you can make, larger changes to work on this. Exercise is, again, very beneficial for stress reduction. We release all those good endorphins, make us feel good. Meditation and mindfulness-based practices, of which progressive muscle relaxation is one option. Visualization, imagining you're in your happy place and really kind of experiencing that, or breathing exercises. Again, this doesn't have to take up a significant amount of your time in order for it to be something that benefits you and helps to reduce your stress levels. I'll take a minute just to kind of fixate on this page here, which just has a bunch of resources, both some websites and some apps that can be really helpful for some of these relaxation-based exercises that I mentioned. Things like walking you through deep breathing, walking you through the visualization or progressive muscle relaxation. Again, these are things that you should be able to implement in your day-to-day life, and these might be some resources for helping you do so. So I'm going to take a little snapshot. Now, the other aspect of migraine care or headache care in general that's important is identifying triggers. So everyone is a little different, and everybody's headache and migraine is a little different. So that means the things that trigger you aren't necessarily going to be the things that trigger your friend or your mom or your, cousin. But these are some very common things that can trigger headache episodes. Weather changes, with all the stormy weather we've been having, certain foods, alcohol is common, loud noises and bright lights, as we'll talk about in a little bit, stress and sleep, and then medications. Headache is a very common side effect for most medications. Now, how do we identify triggers? So Sometimes they're obvious, sometimes we need a little help, and that's where the headache diary comes in. So this is a really fabulous tool for keeping track of your headache symptoms, which can be helpful for your medical provider, but also to help you identify things that might be causing you to have a headache or triggering events. Not necessarily something that happens a minute before your headache, but maybe the hours before. Most triggers can happen up to 12 hours prior to a headache event. So, really looking back, seeing what is outside of the norm for you, and identifying that in a diary might help you pick up on patterns. Food triggers can be even done systematically. You can cut out foods that you think might be triggering migraine and slowly reintroduce them. If you notice a headache occurs shortly after eating that food, that indicates, hey, maybe this is a food that can trigger migraine attacks for you. You should be a little bit more thoughtful about it. Now, I just like to emphasize this point. Migraines aren't necessarily caused by a single trigger. It's kind of all the things that we put into the pile that eventually cause us to reach that threshold of triggering a migraine attack. So, really, at the end of the day, this is about balancing healthy lifestyle habits with the unhealthy ones. So, maintaining those consistent routines, those good, healthy lifestyle habits are going to tip things in your favor and make it harder for you to trigger an attack. Now, I'll just take a quick second to point out there are some over the counter things that can be taken for migraine that have some evidence for being helpful for preventing attacks. Magnesium is one. Riboflavin or vitamin B2 is another. Both of these have a good amount of evidence, are generally very well tolerated. Magnesium can cause a little bit of loose stools, but the formulation magnesium glycinate tends to cause less of that. So that is a good version if you're somebody who's already a little diarrhea prone, and can be helpful if you're someone prone to constipation. Riboflavin can make your urine kind of dark yellow. Other than that, it's a pretty well tolerated medicine. And then coenzyme Q10, which can be used for a few different purposes, also has some evidence in the migraine realm. In general, it's a good idea to always talk with your doctor about supplements before starting them, particularly if you're on a number of other meds, because there can be interactions. But these are really good basic things that can be started if you're somebody who has migraine. So now our patient, Virginia, discussed with her doctor these lifestyle changes, and she's going to keep a diary to help her better understand her headache pattern and triggers. She also decided she's probably going to initiate the magnesium and the riboflavin for migraine prevention. So we've got one happy customer.
All right. Now we're going to shift gears. We're going to talk about a topic within migraines that's specific to why I see patients. I do see a lot of patients with just primary migraines, but this is usually why they end up getting referred to see me a lot of the time. So this is a case of Alexa's a 34-year-old female. She has a history of migraines and headaches, and she's coming in the office for these unusual episodes of visual symptoms. It's happened 3 to 4 times for her. It starts as this kind of shimmering. It grows over minutes. It's affecting the right side of her vision, and she's actually tested it with both eyes. It's more so in the right, but it's there in both eyes, and it lasted about 20 minutes, and then it started to go away just before she got the headache that she usually thinks of as her migraine headaches. So this is a pretty classic description of a visual aura that's associated with migraines. So what is an aura? And specifically, what is a visual aura? So remember before I was talking about those 4 phases of headaches. So we have that prodrome, aura, the headache, and the postdrome. The aura is that period of time, that is that kind of premonitory symptom before you have the onset of the pain associated with the headache. It will last 5 to 60 minutes. And then there's a couple different types of auras that people can have. So that was an example of a visual aura. Some people, I'll say, visual auras are the most common of the specific auras. Far and away, I think, I don't have a specific percentage, but I want to say probably 3/4 of the auras before our visual auras. People can have motor auras. They can have sensory auras, where they'll have numbness or tingling. Same quality in that it's a sensory symptom and that it will kind of last 5 to 60 minutes, and it will evolve over that time and then kind of disappear around the time the headache starts. So visual auras specifically, that same description I was talking about, it's usually gradual in onset. Sometimes the first start of it is, it's all of a sudden something's there that wasn't, so it might feel quick, but it really will start off and then that shimmering expands within someone's field of vision. It lasts less than an hour, and it should be present in both eyes because migraine's a disorder that affects the brain, not the eye itself. There are certain people that will present with one eye, but the typical visual aura should be present in both eyes. If it is, say it's the right side of your vision, it might be more noticeable on the right eye, so it may feel a little asymmetric, but when people will get down to the nitty-gritty of testing and covering either eye when it's happening, it should be in both eyes. Although most people don't test because it kind of scares them the first time it happens. That's why they end up getting referred to see me. But it is a description like this that really reassures me that there's not something more concerning going on. So it's a subjective thing that happens, and everyone experiences something different. This is an example of someone who depicted their what we call a scintillating scotoma. So this sparkling, shining, scintillating, and then scotoma, an area of vision loss. And this would maybe start out smaller and then evolve over minutes. And it's usually that leading edge that as it expands, you get that shimmering or scintillation that occurs. And like I said, it's a subjective event and everybody is different. Here is a good example of different visual auras that people have created themselves of what they see during a migraine, or during the aura before a migraine, I should say, or as part of a migraine. The picture on the one side is someone who drew out their evolution of their visual aura over time as they experienced it. So it's this dynamic phenomena where as things move, they grow. That's okay. The next slide's perfect too. And then, like I was saying, it expands over time. So you may just see something small in the beginning where it's just a shimmering. It's almost imperceptible. Sometimes it's in the center of your vision, off to the side. Sometimes it's a flash, but it can grow and evolve, and it moves and it changes, and then slowly dissipates. It's stuck on. There we go. That last slide was a funny, it was a chart was a studied chart of different types of visual auras that people experience that were meeting criteria for migraine and treated like migraine, and nothing else going on. But I would say it's not typical that everyone presents with these cartoon images of like a cat and a clock, but it was described less classic, but like I was saying before, everyone experiences something different, and you will not experience the same exact visual as somebody else. So don't be scared if the visual aura is different for you even specifically. It may change time to time. So why do we have this funny thing where before we get a headache, we have this evolving, changing visual symptom that precedes a headache? Well, it's because it's part of migraine. It's not that the headache is the migraine, it's that the migraine is the whole syndrome that occurs. So we now know with some newer data, and as we've learned more about migraines and as the science has evolved, we've done functional MRIs of the brain, and we can see that the neurons have this kind of depressed signal on fMRIs or functional MRIs, and we see that depression spread over time. And that's what we map out as part of the headache. And it tends to start sometimes in the visual cortex. So here you can see in the posterior back aspect of the brain there, that would be where it would start. And that is where we process a lot of our visual information, our primary visual cortex. So that's when you get that small center of that just flickering light. And then as it spreads over more of the visual cortex. It evolves over time. and then it continues on and then is followed by the painful component of the headache. And migraines, along the same lines of that it is a syndrome that occurs. Can you have migraines if you don't have a headache? You just get the visual aura. Yes, it's actually, I want to say it's not common, but it's not uncommon. Specifically for patients I see because of what I do, I have a lot of patients come in who just have the visual aura and don't get the headache. And you can have a migraine with visual aura. You can have visual aura with and without a headache. It can be one or the other sometimes. Some people, particularly later in life, may develop just isolated visual auras without much of a headache or migraine history. So everyone can experience a little bit of everything. It doesn't always follow the rules. But how do you deal with the visual aura when it happens? I think one, recognizing the signs early. So you know that earlier treatment for your headache, the things that, taking rest, hydration, fluids, if you have medications for headaches, if you take it at the onset of that visual aura, you're more likely to abort or shorten the headache duration. So knowing those signs early and being aware of what those signs are. So one, it's not scary or concerning to you the second or third or next time it happens. And understanding that it will resolve and it's not a concerning thing. It is for the visual aura specifically in terms of treatment. It's a tough thing because they're usually short enough that by the time somebody makes it to their medicine cabinet to get something, it's almost kind of nearing the end of it anyway. And by the time the medication would take effect, it certainly is done for the visual aura, not for the whole migraine itself. But a lot of times too, understanding and working on those lifestyle interventions that Dr. Jicha spoke about before can really be helpful with dealing with visual auras. If they are really inhibitory and getting in the way of someone's lifestyle because they're having them frequently, that's when we have some things that we will try. But sometimes medications cause more harm than good if lifestyle things and adjustments can minimize those symptoms. So, light sensitivity, another really big prominent feature in migraines. Start with another case. So Erica, a 33-year-old with migraines, both with and without visual aura, is coming into the office to talk about her increased light sensitivity. She's been having a lot of difficulty at work. The lights are really bothersome. She works in IT, so she's on screens a lot. Office lighting is notoriously very bright. It's really bothersome to her. It's starting to affect her work. She's not comfortable. She feels like she's not working to her most efficient state because of it. Is there something that's going on? Well, in her case, I'll say with making sure that you have a healthy ophthalmologic exam and no other cause, migraines and light sensitivity and photophobia. So photophobia is the medical term for sensitivity to light. They're closely linked. Photophobia is a common symptom in migraines, and migraine is the most common neurologic disorder causing photophobia. Dry eye is the most common ophthalmologic cause of light sensitivity, but migraine is the most common neurologic cause that causes light sensitivity. They are so linked that it is one of the major criteria when we look at the internal classification of headache disorders. So that slide that I presented way back then, under the must have one of the two following features, photophobia was one of those major components. So they're so linked, it made the diagnostic criteria part of it. And that light sensitivity can happen with an event, but it also happens in general and may be more prominent even in between. So people with migraines tend to be more light sensitive, both during and between headaches. During the headache, that's why people will put on sunglasses, go lay down in a dark room. It just feels better to have that on. And that's okay. Other people can be triggered by lights. So most commonly, people will discuss bright fluorescent lighting, like our patient was talking about in their office, changes in lighting conditions, and a lot of screens and computer usage can be triggering for headaches or worsening them. And the aura with the vision changes can occur with light sensitivity. So can the headache, but like we were talking about, migraine kind of classifies it as this syndrome that lasts over multiple phases, and light sensitivity can be prevalent in all of them or some of them. And it's very common, right? 30 to 50% deal with some pre-full headache attack light sensitivity. 90% of patients with migraine with aura have photophobia around this time. So it's just a really common thing that's associated with it in all of the four categories. So what can we do for light sensitivity? For fluorescent lighting and office lighting, a really good thing to consider and think about is certain types of lenses. So fluorescent lights have a specific wavelength within the light spectrum that they emit, different than the sun, which is a broader spectrum. And certain colors have a lot more painful features to them based off of studies. So FL41 tinted lenses or rose tinted lenses block specific wavelengths that match fluorescent lighting. They are rose tinted. They make them in actually quite stylish options now. You can find them online. Most stores have them. You can buy them over the counter. I always say try them out. If you like them, then talk about getting them put on glasses if you find them very helpful. Or you can just use them as needed. And some of them you can get the go over glasses. They're good because you can use them around a lot of different times. Outdoors, bright light, sunglasses are appropriate, but indoors, when you don't need sunglasses and you don't want to be filtering out that much light, this is a really good way to reduce a lot of that light sensitivity during the headache. People will use blue blocking sunglasses or other types of filters. Those don't have as much evidence-based data, and these can provide a lot of help as well. But I say whatever helps in those situations. Avoiding overly dampening that with really dark sunglasses can be helpful. Yeah. And then for that light sensitivity in between, how can you help? This is a mnemonic that I kind of created. It's not anything official, but I say give yourself a break. And a lot of it overlaps with those lifestyle things too. So breaks with prolonged screen time. This is a big one, right? We're in a world of screens. We're at work. You're on your phone. We don't blink as much when we look at screens because of the refresh rate. The light can be irritating. It causes dry eye. So the 20-20-20 rule is what I say. So for every 20 minutes you're on a screen, close your eyes for 20 seconds to re-wet the surface, and then stare off into the distance for 20 seconds to just relax the eyes, or just giving yourself breaks from using screens for too long a period of time. And then exactly what Dr. Jack was saying, it's the regular sleep schedule, exercise, adequate hydration, and a healthy diet. I like to think of the lifestyle adjustments that you can do is that it's consistency. So our brain likes consistency. It doesn't like when we fluctuate that schedule too much because that's disruptive. Sleep is the perfect example. If you're somebody who gets 8 hours of sleep every night, but you get 8 hours of sleep starting at 9 p.m. and the next night you go to bed at midnight, that shift is enough to be a schedule change, and that can irritate the brain. So it's the regularity, the consistency that our brain likes. So how did our patient do? She started using FL41 tinted lenses at work. She started treating dry eye, so she was using artificial tears regularly throughout the day. And she's been working on a lot of the lifestyle modifications, and it wasn't an immediate fix, but slowly over months, she started to notice that her symptoms are gradually improving, and she's no longer afraid of going to work every day. And that's a pretty common time frame. A lot of these changes don't happen overnight. You have to work little by little, inch by inch, and look back 3 months, look back 6 months, and see where you were at before. And it's that when you'll realize that you've really made a significant difference in kind of your life and behaviors and how you're doing.
Great. So now we'll talk a little bit about when you need to see a doctor. You know, when is a migraine not a migraine? So this is Jenny. She's a 62-year-old female with a history of high blood pressure, diabetes, and she's coming in for evaluation of headaches. Now, these headaches are new for her. She has no prior headache history, and she describes them as severe, throbbing, the right temple and eye. So, accompanied by nausea, light, and sound sensitivity. That's like a migraine. She's also started to notice some decreased vision in one of her eyes. And it seems to be there even when she's not having a headache episode. Jenny is pretty anxious about her symptoms, and wants to know what's causing these headaches. She's also interested to see if any evaluation is needed before treatment is discussed. So, does it sound like Jenny's symptoms require any further evaluation?
Yes.
Yes, uh, they do. Um, there are red flag features, when you see a provider for headache, there are a few things that, we listen for when we're getting a history that tell us, maybe there's a chance something else is contributing to the headache or even entirely causing the headache. Some of these red flag features include new onset of headache. Jenny never had a headache before, no history of headaches as a kid or as a teenager. So this is entirely new for her. Once we reach a certain age, that becomes a little more concerning. If she did have a headache history, but her headache pattern changed, let's say she went from having one headache a month to having a headache every day, that can clue us in. Maybe something has changed that could be contributing to the worsening of her migraine symptoms. Let's make sure we evaluate for a secondary headache. Again, meaning a headache caused by another medical problem. If you have a sudden onset severe headache, we call it thunderclap headache, a headache that goes from 0 to 100 in, seconds to minutes, can be concerning for a few different medical conditions. So that requires more emergency attention. Most migraines have a gradual build. So even a rapid gradual build means that this is evolving over many minutes and shouldn't kind of, be at its maximal severity in a very short time frame. Should take at least a little bit of time to get there. If you have new visual changes or other neurologic deficits, weakness should not accompany a headache attack. If that's something that happens, you need to, see your doctor urgently. Same thing can be said for visual changes. If you're noticing visual disturbances that seem to be present whether or not you have a headache, that might warrant some further investigation. And honestly, if your pain is severe, interfering with your daily function, you might need to kind of escalate to that next level of care. So that would be another thing to keep in mind when thinking about seeing a doctor. Now, what kinds of secondary headaches are we talking about? There are a number of different secondary headaches. Again, we have our primary headache diagnoses like migraine and tension headache, which are kind of intrinsic to you as a person, to the way that your nerves and your brain functions. Secondary headaches are caused by something that, um, you know, another problem that can hopefully be addressed in a slightly different way. All of the testing we do for migraine is really just to rule out some of these secondary causes of headaches. Some common ones include headaches related to high blood pressure, very common for high blood pressure to cause headaches. Sleep apnea is a very common cause of headaches, particularly headaches that occur in the morning. So if you're waking up with a headache many days, especially days when maybe you're not getting your sleep apnea treated, that could be a reasonable explanation. Medications. Medications are very common to cause headache. If you have any prescription medications, you probably see headache as a side effect on almost every list of those. Doesn't mean every headache or every medicine is likely to cause you headache, but it is a possibility. And there are some that we see doing this a little bit more so than others. And then headache related to an infection. If you got sick with the flu, headache is a very common symptom that accompanies that. So that's another very common cause of secondary headaches. Some others, cervicogenic headache. This is headache related to the neck, so your cervical spine. If you have arthritis or degenerative changes here, that can pinch on nerves and cause a lot of tension and a lot of pain in the areas of those nerves. Occipital neuralgia is a somewhat related condition. We have occipital nerves in the back of the head that can be irritated, either from, again, arthritis type changes in the neck or just muscle tension pinching on the nerve, and that can cause a shooting electric type headache. So some of these are some fairly common secondary headache disorders that we see and that we want to assess for when we're seeing a patient for headache. Now, are there things that can reassure us that what we're dealing with is a primary headache disorder like migraine or tension headache? Yes. If you have a long-standing history of headache, if you have a headache that's been present since you were a kid or a teenager, that can be very reassuring. If you're a female and you've had headaches occur in timing with your menstrual cycle, that's very common in tension headache and migraine. So that can be reassuring. If you're having breaks in your pain, if you're not having a continuous amount of pain, that can be something that reassures us. And then if you have close family members with headache, conditions like migraine tend to run in families. So while every individual in the family's experience of migraine may be different, does tend to be more common in that lineage. So while these things don't necessarily mean you don't need to see a doctor for your headache disorder, they are things that can make us feel a little reassured that there's not something else going on that's contributing to the headache that they're experiencing. Now, medication overuse. This is another important topic to discuss. Henry's a 48-year-old male. He has a history of migraine and tension type headache, and he's coming into the office to discuss his headache worsening. So he went from having headaches 3 times a week to having them every day. He's been treating with over-the-counter medicines such as ibuprofen and acetaminophen every day. Now, Henry wants to know, why are things so much worse? Why have they increased in frequency despite having stable health, stable lifestyle factors? He's keeping that good, consistent schedule that Dr. Spiegel mentioned. What do we think is causing the worsening of his headaches? Sometimes it's the things we're doing to treat them. So rebound headache occurs when you're taking medications frequently for the treatment of headache. So if you are somebody who has migraine or tension type headache, taking too much medications to treat them as needed can actually contribute to headaches. And we end up in this lovely cycle where we're feeding more medicines to treat the pain, which is then contributing to our pain. So how much is too much? What are kind of our cutoffs for thinking rebound headache is at play? So for things like most of our over-the-counter meds like Tylenol or NSAIDs, using those 15 or more days in a month for multiple months can cause a rebound headache. Combination meds like Excedrin only need to be used 10 or more days in a month. And then medications like opioids and even the triptans, which are migraine-specific medications, again, only need to be used 10 or more days in a month to contribute to a rebound headache. Now, these are basic guidelines. Again, everyone with headache and migraine is a little different. So if you're somebody who's maybe approaching that, number of days in a month and you're feeling like things are starting to worsen, you might need to step back a little bit to make sure that this is not a contributing factor.
Dr. Jackie, can I add one thing?
Yes,
I
absolutely.
I always like to think too, our brain has no idea why we took that medication. So I get a lot of patients that come in and they're not taking Advil for their headaches or migraines, but they are taking it every day for back pain. And so our brain doesn't know and it doesn't differentiate. So it's days of the month total how you use it.
Yep. Again, if you have migraine or tension headache, that's a possibility, and again, something to be thoughtful about. Maybe it means you have a discussion with your pain management doctors or your general practitioner to discuss alternative treatments for whatever condition is causing you to treat your pain in that way. We have lots of different modalities of pain relief, so this doesn't have to be a popping pills around the clock thing anymore. There are other opportunities available. And again, a lot of these lifestyle things can make a big dent in this as well. So even non-pharmacologic ways to get around this. But we'll go next through a case that kind of walks you through what happens when somebody comes into our office and is having headaches and, needs some help. So this is Tanya. She's a 40-year-old female, 41-year-old female. She has a history of anxiety and she's coming in for headaches. Her headaches have been there since she was a child. So green flag, we're a little reassured already. Headaches are severe, throbbing, squeezing in the front of the head. She does have nausea, light and sound sensitivity, and a lot of stiffness of the neck, which is another very common migraine feature. And she's noticed that things have sort of increased over the last 20 years or so. She's getting them around 3 or 4 times a week now, and they're really interfering with her life. So she's never actually seen a doctor for this before. She's previously managed with lifestyle changes, trigger avoidance, over-the-counter medicines, but finding that it's no longer enough to manage her symptoms, and she wants to know what options are next for her. So what can we do? What can we do to help Tanya? So when it comes to headache and migraine management, prevention therapy is one of our first kind of broad categories of treatment. So when we're ready to get to medication type options, we look at starting something that can overall help to improve headaches. And that can come from a number of different categories of or classes of medications. Now, until fairly recently, maybe the last 5 or 6 years, we didn't really have a lot of medicines that were designed for headache and migraine. Most of the medications we even still use for headache and migraine were actually borrowed from other classes of medications. Heart medications like propranolol, metoprolol, seizure medications like topiramate and valproic acid, antidepressants like venlafaxine and amitriptyline. Migraine is just such a common condition that people were on these medications for various other reasons and were able to find, hey, my headaches are actually doing a bit better, which is where we discovered, they had some utility in the treatment of headache and migraine. We do have some treatments that have emerged more recently. The CGRP monoclonal antibodies here are an example of some of these that are a little more targeted for migraine. So CGRP is a pain molecule that's well known to be involved in the migraine pain process. And these medications help to target that molecule and make sure it's not in use and in play in the migraine. Botox is another very common therapy that we use for migraine prevention. But my little caveat to this is that typically providers need to visit some of the older medicines before we start to get approval for some of these newer medicines. There are specific criteria that insurance companies put out for us. So if you have a doctor who recommends something from those first couple of classes, they're doing the right thing. Those are our first line therapies. But eventually you'll get access to some of these newer medications that might be out. This is a picture of Emgality. Now, what are we actually hoping to do with prevention? A number of things. We're hoping to make migraines less frequent, less intense, not as long lasting. We're trying to improve quality of life, let people function better, less disability. Migraine is one of the leading causes of disability in the world. And then make it so that when you take your as needed medications, they work better and you have to use less. So this is a really prime strategy for dealing with rebound headache or that medication overuse headache. Starting up prevention should make you need to use medications less. So can really help to sort of help you wean off of whatever you are overusing. Now, something important to keep in mind. Again, this is not a one-size-fits-all model because not everybody with headache and migraine is the same. There's a little bit of trial and error involved in medication prescribing in headache and migraine. So it's really important to, voice your preferences and concerns with your provider, but this is really sort of a team-based approach to get you towards the ultimate goal of having less and less severe headache attacks. But we don't always hit it right on the first try. Sometimes you do have to try a few things to get the right cocktail on board for you. The other broad category of medical treatment is acute therapy. So again, a number of different classes. You have your anti-inflammatory meds, things over the counter like Advil, Tylenol, aspirin, triptans, which are migraine-specific medications, but have been out for many years at this point in time. Things like sumatriptan or Imitrex is the other name for it. Gepants, which are some of our newer migraine medicines. Nurtec, Ubrelvy, and Zavspread are a few examples of those. And anti-nausea medications, things like metoclopramide or Reglan, Compazine. So number of these can be helpful for headache conditions. Again, overusing some of these can lead to rebound headaches, so that's something to keep in mind. This is really about building a toolkit so that you have things you can take when you have a more mild headache, when you have a migraine attack, when you can sense some of those prodromal symptoms coming on, or even that the start of a visual aura, to be able to help abort an attack and resolve it. Some good tips for using as needed medications can be really helpful to try to identify your migraine prodrome. You know, many of these can be taken really early into the migraine process, even sometimes before the migraine is actually even set in. So it can be helpful to recognize the signs that'll let you know when to start thinking about having a migraine medicine at hand. Again, a headache diary is the best way to do this. Use it as a tool to understand what's going on better. Treat early. All pain meds work best if you take them early when the pain level is still low. So don't wait for your headache to go from, a 2 to an 8. Migraine meds or as needed meds are not going to work as well as at a level 8 as they might at a 2 or 3. So if you get it into you early, hopefully by identifying the symptoms leading up to it, you can better treat your headache, lead to shorter duration and less pain. And then again, avoiding rebound headaches. So be thoughtful about how many you're using in a month. If you feel like you're over relying on one, think about discussing with your doctor an additional option so that you're not over relying on one, or even starting a preventive medication so you don't hopefully need to use as much of your acute medications. So Tanya decided she would like to trial venlafaxine for migraine prevention. She's given rizatriptan to take for her migraine attacks and naproxen for her tension type headaches. At her 3-month follow-up, she notes that her headaches have decreased to 1 per week. And when she does have migraine attacks, the rizatriptan resolves them within an hour. So we have another happy customer. Again, these are not necessarily cures for headache and migraine. These are treatments aimed to make them easier to manage and to interfere with your life less. So headaches will still happen, migraine attacks will still happen. It's about having the tools to combat that. So with that, I'll say thank you for your time and attention today, and I'd love to answer any questions.
Yeah, I can take the first question. They had just typed it up. So somebody had asked specifically regarding the symptoms of sinus congestion headaches, and having been told by an ENT doctor that they thought it was a migraine because it responded to a triptan. And I'll say, this is also it's not an uncommon scenario that we see. We talked a little bit about, unilateral headaches, throbbing headaches, the location sometimes, although we like to think maybe it's helpful for back or front, but the nerve that does the coverings of the brain and gets activated in migraines does face, it does this area, eyes, and patients can have pain in different locations. So sinus pain can be a presenting symptom of migraine. I see it a lot specifically, patients coming to me. I saw someone today who had eye pain. It was very specific, very bad eye pain that was triggered and resolves with the triptan. And when you actually dig into the history, they really started to expand upon a lot of these prodromal symptoms and then these auras or the postdrome, and they really fit a migraine criteria. But it can be difficult. And that's why sometimes people will go see other doctors before it's realized that it may be a migraine. So it certainly is a possibility.
Yeah, I think the other thing I'll add to that, so this is a very common situation. There is some research and data to suggest that up to 80% of people who have previously reported sinus headaches actually do have migraine. And one of the things that makes this extra complicated, besides just the various pain locations that Dr. Spiegel mentioned, is that you can have things like congestion, runny nose, watery eyes, itchy eyes, a lot of these sinus-based symptoms with migraine attacks as well. So that's when it, kind of putting the whole picture together can be really helpful. Keeping a bit of a diary can be helpful. And, honestly, if you're responding to the triptans, it sounds like this is probably migraine.
Yeah, I didn't want to jump and say I agreed with the diagnosis because we don't know, we haven't met you, but I think it's not an unreasonable thought. Next question. You want to take this one? Trade off?
Sure. So one person wrote in asking about the options for migraine during a menstrual cycle aside from lifestyle adjustments. So for my menstruating females, this can be a really troubling time for migraine around the period, typically a little before and a little during the menstrual cycle. And we think it's that, kind of drop in estrogen levels that are leading to these headache attacks, which are known to be more frequent around your period, more severe, more difficult to treat. So they can be really nasty around that time of the month. There are things that can be done from a medication perspective to help address these worsened headache episodes. Keeping a diary of both your period and your headache symptoms is kind of the first step. So understanding that association, it's a little easier to combat these menstrual migraines if you understand when they're going to occur. Then sometimes we can use medications that last a little longer in order to try to prevent them before they happen. So you can see why having a really good understanding of when you're going to get that worsening migraine attack is important. And again, might enable you and your physician to work out a strategy to prevent them before they even occur. Being on an overall preventive medication should also help, but there are again some smaller, shorter term strategies that can be employed for headaches during menses as well.
The next question was someone had asked about lightheadedness and no pain. What kind of doctor should they see? There's a lot of things that can cause lightheadedness, whether it's imbalance, feeling near syncope, dizziness. I think a good place to start really is primary care for something like this, because there's a lot of different things that present like lightheadedness. So making sure that you get a good checkup for things like, do you have a good blood count? What's your blood pressure, blood sugars? Make sure that, similar to how we think about the foundation of head work and starting there, making sure that you start with that foundation of overall medical assessment. And then depending on how that kind of evolves and shows can help differentiate it into certain different people and doctors, whether that ends up with low blood pressures and going down that route versus other things that end up in maybe an ENT or in your nose throat doctor's office for dizziness. There's a lot of different pathways that can end up taking.
Do you want to take the next question?
I hadn't read this next one. Yeah, this one's an eye roll. I hadn't read it yet. For you. I have uveitis and constantly have pain that is one-sided, but does alternate from left to right, never both sides at once. It feels like a throbbing pain behind my eye. What would be considered a migraine? Sometimes my head doesn't hurt. I have had migraines and the pain is different. Should I contact my neurologist about it? If you are having uveitis, uveitic flares is a very common, and one of the main symptoms is eye pain. And I'll say, without knowing specifically how you've presented in the past, but this is where it's helpful to see a doctor, right? And have them talk it through with you, and knowing your history and exam, because uveitis is associated with eye pain, it may just be one of those secondary headaches or related symptoms and syndromes. I think if you were to see your ophthalmologist and they didn't have if they felt like there was nothing that they thought was causing it, then it would be something worthwhile discussing with your neurologist. But I would start with that.
Very good.
Next one, I can take that one too because it's light sensitive related.
Sure.
Can sunlight exposure, even if wearing a hat and sunglasses, be an exposure trigger for a migraine, or is it more typically indoor lighting? Any and all light can be triggering. That doesn't mean it's going to be. I think we talked about a lot of triggers today, and I want to reassure you guys, everyone here in the audience, that this doesn't mean that you're going to go and develop light sensitivity and have this associated with your migraines, or that you have a change in frequency in your migraines and that red flag symptom means that you need to see your doctor and get an MRI. A lot of these things can fluctuate and change, and even when you see the doctor, it may end up just being a conversation and talking about it. But people can commonly be triggered by sunlight as one of them too.
Our next question, occasionally on a long airplane flight, I will get a terrible headache. Is it cabin pressure? And on some flights, the cabin pressure isn't as good. So air travel is a common trigger that I hear from my patient population. And there are potentially a few reasons why that might be. Certainly the cabin pressure, changes in pressure can be problematic. I also have a number of patients who are very easily triggered by weather, changes. That barometric pressure shifts in the atmosphere can be triggering for headache and migraine. Even altitude can sometimes be a trigger for headache and migraine. Flights are also very dehydrating. You're not moving as much. So there may be some other factors that can contribute to that as a trigger. Good to know about, making sure that you're kind of well equipped on a flight to treat a headache or migraine. If one is likely to occur, can be really helpful and beneficial.
The next question asked about an AARP document discussed using specific green light bulbs that can be beneficial. I know we had talked about specific light filters, and blue, and the image I depicted had green light as one of those frequencies that can be aggravating. I'll say I don't have as much experience with these green light bulbs that you've mentioned here. I have heard about them. I don't know the specific data behind them, aside from the fact that it's not the full green wavelength spectrum, and a lot of these frequencies aren't as, I'll say it's probably helpful, and I think that trying them out and seeing if it's helpful is an okay thing, as long as it's not breaking the bank and costing a lot of money. Try one, and if you like it, that's okay. For the green light bulbs, it's a specific wavelength of green light. So those light bulbs are I don't know if it's a lower frequency or wavelength, but it is not the nociceptive or painful one that we see commonly in the fluorescent, whiter, green, blue, harsher lighting.
From my understanding as well, there are a lot of different people selling these green lights. Sometimes they're better than others, meaning some let in more wavelengths of light, which might be irritating to the eyes, and some are better at only letting through those good, soothing green lights through. So I would just make sure to do a little research into that. Yeah. Sounds like you might have a version that has been helpful for you. So that's wonderful.
The only thing I'll say when it comes to light filtration is you'll see a lot of different filters out there. The main thing that I think about is the overly darkened sunglasses. Because we all know if we go into a movie theater and we watch a movie for 2 hours and then we come outside, it is bright and your eyes hurt no matter what. So if you're wearing dark sunglasses a lot, you adapt to that dark environment. And when you take it off, it's more painful. So it's whatever filter gives you comfort and allows enough light in that you're not overly adapting the eyes. The rose tinted FL41s have the most evidence behind them, which is why we recommend them, but people find help and benefit from other ones.
Okay. This next question's a little more person specific. I can try to answer to the best of my ability. So this patient or this person has giant cell arteritis, which is a secondary headache disorder, and they've been on steroids for years, and are having some trouble getting off of them. It is for this condition, it is important to kind of have a good team working with you. So make sure you have a neurologist, an ophthalmologist, and usually a rheumatologist, because there are other medication treatment options. I'm not sure, again, without specifics, what would be a good treatment choice for you, but your provider team should be able to help guide you through what are options for you. So really about just building a good team in your headache care.
A great
Any other
example of a
questions?
secondary headache.
Yeah, very good example. And
And
requires much different treatment than everything else we talked about today. So that's why one of the reasons why recognizing secondary headaches is so important.
and why it's really important when you do have some secondary headache to work with a specialist in that condition, because I see a lot of patients with giant cell arteritis because it affects vision, and there are options and things that can be done for that. And I would be hesitant to start a headache specific therapy for something like this, at least until I felt more comfortable in knowing how things evolved.
Mm-hmm.
They were good questions.
Yeah, very good questions. Hopefully you all got something out of this talk.
Thank you, everyone. If there are no more questions, I just want to remind you that this lecture has been recorded, and once edited, it will be emailed to everybody who registered for this event and also available on our website in the coming weeks. The next lecture is going to be in July, and coming up August, September. We have one each month. You can check our website for that information. So Dr. Jicha, Dr. Spiegel, thank you so much for your time this evening. That was really informative. And I hope everybody got some useful information from this and will seek your guidance for their respective issues. Thank you so much, everyone.
Wonderful. Thank you.
Thank you all for coming.